Okay.
Does it say you're broadcasting?
Yes.
Okay, awesome. Thank you.
Yep, no problem.
Well, hello everybody and happy Friday. Thanks for spending your Friday with us. Looks like there's still some people hopping on, but we are going to go ahead and get started here. I'm Anna Vivanti. I help with the training program here with the Illinois Crisis Prevention Network. Welcome. If you guys are new to us, we have started a new initiative for behavior analysts where we're trying to offer a monthly training just for you guys that's relevant topics in the field, but then also brings in the ABA part of it. So I know I put a little comment in the chat box, but just a reminder that this is based on ABA and the CEs will be provided to BCBAs and BACBs. We are an ACE provider, so we will provide that to you. If you're any other profession, you're not going to receive CEs for today. However, you're more than welcome to listen in if you would like to. A couple of things. So if you are new to Zoom, then go ahead and bring up your chat box and you'll see that I started putting some comments in there. So this will be our main method of communication. Everybody's cameras are turned off and you're automatically muted, so we can't see you or hear you. And this is kind of how we're going to run the workshop today. So if you guys have questions, comments, anything like that, or want to interact with each other or say hi or anything like that, go ahead and put that right in the chat box. There's a little drop down menu next to the two. If you click on that, make sure that all panelists and attendees is selected. If you only have all panelists on there, then you'll only, your messages will only go to Leah, Emily, and myself. But if you have all panelists and attendees selected, then everybody can view it. So we use that for our communication. We are going to take a 10-minute break halfway through so that they can go through the chat box and look at the questions and then try to answer those throughout the last portion of the training. And then at the end again, then they'll kind of just skim through and see if there was any questions that they need to look at again. Comment questions for CEs, you will receive your CE following the training. You'll receive an evaluation from Jenny Gra, the training coordinator. You'll fill out the evaluation, put your license number in there and then send that back to her and then she'll send you your CE. Just because we're ACE provider, we have to make sure we have evaluations for each person. So make sure that you receive that and send it back. If you don't get the evaluation, you can reach out to Jenny Gra and she'll make sure she gets it to you. And I'll go ahead and put her contact information in the chat box as well so you guys can locate that. Give her like 10 to 14 business days to make sure that she has time to get them all out. And then if you still haven't received it after you did your evaluation, then you can reach out to her as well. For receiving mailings, if you guys want notification for our upcoming trainings, if you go to icpnnews.com, you can register to receive those mailings so you're notified when things are open. Some of our workshops are for BCBAs for the ACE provider and some are not. So just make sure that you look for that ACE provider logo or towards the bottom, it'll always say who the CEs are for. So just make sure you check that out. So icpnnews.com, and I can put that in the chat box, or you can follow us on Facebook under Illinois Crisis Prevention Network, and you can see them all posted there. We just posted a few new ones. I think we have compassion fatigue, another one in medication, personality disorders, borderline. So we're adding new ones every week. So go ahead and check that out. The presentation for today will get emailed out to you guys as well with your continuing education. So you'll have a copy of that. And then we're recording this as well. So then that'll be posted to our website where all of our recordings are under. You don't receive CEs for rewatching it, but you can just view it later if you would like to. Oh, one final thing, Leah and Emily are going to take out the ABA part of it and present this again in the near future. So if you have a colleague or a peer or you are a case manager, Q, social worker, anything like that, and you want to attend it in the future to receive CE credits, they are going to take out the ABA part and gear it more toward middle management, case management, and just kind of condense it down. So watch out for that too. So we are going to provide it to the community as well in the future. I think other than that, we are set to go. If you guys have any questions or comments, go ahead and put it in the chat box and I'll make sure that I get to it. Thanks, guys.
All right. Hello, I'm Leah Schilke, so I'm a BCBA.
And my name's Emily Dietz. I'm at LCSW.
All right, and we are going to get started talking about clinical considerations for working with transgender people within the IDD population. Okay. So before we get started, a quick disclaimer. We feel it's important to share our clinical findings about this topic as the transgender population as a whole is typically underrepresented. People who are transgender and diagnosed with an intellectual and/or developmental disability can experience compounding challenges that should be acknowledged and supported accordingly. We're not part of the transgender IDD community, therefore cannot speak for these individuals and their specific experiences. Our goal is to provide generalized information to encourage clinicians to expand their awareness and consider potential factors of supporting people in this rare but valuable population. Specifically, the field of behavior analysis has not published research that encourages the individualization of treatment plans for those who identify whose identities may require these additional considerations to provide effective and beneficial support. Since all BCBAs should use evidence-based practices and there's no clear research on this subject, conclusions have been drawn for this presentation based on historical ABA literature and information regarding the frequent disadvantages that transgender people and people with IDD are faced with. And now a language disclaimer. Language regarding the LGBTQ+ community has changed over time. Many words have a harmful history and have been used to oppress and discriminate against LGBTQ+ individuals. Many of those words are still considered harmful today, while other words have been reclaimed by individuals. No assumption should be made about an individual's identities and language surrounding those identities. Reflecting the language used by each individual and clarifying language as needed is important to provide a safe and respectful therapeutic environment. Appropriate language, we're going to discuss a few different things. So first, appropriate language used to define sexuality and gender, social significance of supporting personal identities, commonalities regarding personal identity affecting behaviors, typical ABA practices and how these may affect transgender people with IDD. We will examine current clinical practices regarding individualizing treatment plans based on personal identities and how this can impact outcomes. We will discuss recommendations for clinicians to ensure practices are inclusive and supportive of transgender people. And we will provide tips to engage in ongoing social awareness efforts and sharing inclusivity within professional practices with colleagues.
All right, so I'm gonna take over here and just start with some definitions. Give me 1 second. I need to move our video so I can see our slides. All right. So starting with sex defined, we want to start talking about sex assigned at birth. The assignment and classification of people as male, female, intersex, or another sex is based on a combination of anatomy, hormones, and chromosomes. It's important that we don't simply use the word sex when we are talking about sex assigned at birth because of the vagueness of the definition of sex and its place in transphobia. Chromosomes are frequently used to determine sex, although not as often as genitalia, and chromosomes do not determine genitalia. When we are talking about intersex folks, intersex is defined as a person who is born with sex chromosomes, external genitalia, and or internal reproductive system that are not considered quote unquote standard for either the male or female sex. It is estimated that 1 in 2,000 individuals are born as intersex. And I wanted to make an important note regarding intersex folks. Although we are speaking about transgender people today, I wanted to add a note saying that it's a pretty common practice in the US that unnecessary surgeries are performed on intersex infants and children, so they will align within the gender binary. These surgeries can be physically and psychologically harmful. They're done without the consent of the individual, even though they can be safely postponed until that person's at a consenting age. Often, particularly with external genitalia, the surgery is just cosmetic and it's not medically needed. And I wanted to highlight this just to really show that our society in particular, because we are talking about strictly within the United States, there's really a fixation on quote unquote fixing people. So they really fit within the gender binary. And I think that kind of aligns with the viewpoint that we're going to be discussing more regarding people who are transgender. Going into defining gender. Gender identity is one's personal sense of being male, female, neither of these, both, or other genders. For people who are transgender, their sex assigned at birth and their own internal sense of gender identity are not the same. Cisgender individuals, their identity corresponds with their sex assigned at birth. Gender expression and presentation is the physical manifestation of one's gender identity through clothing style, hairstyle, voice, body shape, etc. Most people who do not identify as cisgender seek to make their gender expression, how they look, match their gender identity, who they are, rather than their sex assigned at birth. So it's really important to note that with gender identity, it's completely independent from sex assigned at birth. Gender expression often aligns with gender identity when a person feels safe to express themselves in that way, but gender expression does not necessarily correlate with gender identity. Going into a little bit of attraction and sexuality. Sexual orientation is who an individual is attracted to and who the individual feels drawn to, whether it be romantically, emotionally, and or sexually. All those things can be independent as well. Common sexual identities that we may hear include homosexuality, heterosexuality, bisexuality, pansexuality, asexuality. These are also completely independent from sex assigned at birth and gender identity. And again, romantic attraction, emotional attraction, sexual attraction, those can all be independent from one another as well. So just to clarify those things a little bit, if you have a cisgender male and a cisgender female, that may be defined as a heterosexual relationship. Whereas if we have a cisgender male and a trans female, that would also be defined as a heterosexual relationship. It's really important that as we are defining and putting labels on things, that we are asking the person how they are defining those things themselves, and we're not putting labels on things on those things ourselves. And it's just really important to consider you know, how the person is identifying themselves as we move forward throughout this conversation. When we look at the word queer, queer is one of those words that Leah mentioned that has a harmful history within the community. We do see a lot of people kind of regaining that word and really trying to add their own voice to that word. It has historically been used as a slur, but it is being reclaimed by some. Today, it's more so used as an umbrella term, used to describe individuals who do not identify as heterosexual or cisgender. Queer can be used to express sexuality or gender. So we have the gender unicorn here. This is a infographic used to just break down everything I talked about. You can see here that everything is very individual and they are independent from one another. So you have gender identity, gender expression, sex assigned at birth, who someone may be physically attracted to, as well as emotionally attracted to. A quick note that under the gender identity up at the top, you do see an other category. And that's because some people may not identify with a specific gender. In this case, you may hear the terms agender, genderqueer, or non-binary. There are other genders besides male and female, and not all cultures operate on a male-female binary as we do in the United States. It is primarily a European construct, the gender binary. Another note on this slide is on Netflix, there is the newer Bill Nye show called Bill Nye Saves the World. He does have an episode on gender, and he explains this pretty similarly to this image here, and he uses an abacus. And what's cool about that is that it really is able to show that it is a spectrum. Everything is a spectrum, and it's not black or white, one thing or another, especially in regards to really all of these things on here. They can shift over time. They can shift within the hour, and that's okay. And it's a really good description of how that works, and it's a nice visual to see. All right, so we are going to go into a little bit of population history. So a brief history of the IDD population. It really is a dark history. In the 1800s, people with intellectual disabilities were placed in institutions with no treatment. People with physical disabilities such as cerebral palsy were also institutionalized due to their perceived intellectual disability to an untrained eye. Institutions had really, really poor conditions. The goal was just essentially to separate them from society. Institutions were understaffed, they were unsanitary, there's a lack of overall personal privacy, and people's basic needs just weren't met. As we move into the late 1800s, it was determined that people with intellectual disabilities could benefit from schooling, and they were able to complete small tasks. Going into the early to mid 1900s, there was the introduction of psychoanalysis within the US, and people with intellectual disabilities and developmental disabilities did not fit this model. Psychiatrists were removed from their treatment teams, and antipsychotics were no longer part of the medication regimen. As it was said, there was no benefit to it. And going into the mid to late 1900s, that's when we start to see it growing into the model that we currently have today. We see that deinstitutionalization. People's families got a glimpse into what these institutions look like, and they were quite honestly horrified with what they saw. So that's where we see that movement towards community-based living that we see today. Going into a brief history of trans persons, specifically within the field of psychology. In the early 1900s, we have Magnus Hirschfeld. He was a medical doctor and an advocate on behalf of sexual minorities. He maintained that the belief that sexuality was not a choice, and he was among the first to distinguish between same-sex attraction and, as he called, transsexualism. Harry Benjamin was actually mentored by Magnus Hirschfeld, and he came about in the mid 1900s. He was also a medical doctor. He published content distinguishing transsexuals from homosexuality and cross-dressing. He advocated against what we would now call conversion therapy and advocated for hormone therapy and reassignment surgeries. And he also founded what is now known as the World Professional Organization of Transgender Health. Despite all of this going on, we did not see anything regarding gender identity pop up in the DSM until the DSM-3 in 1980. The DSM-3 labeled transsexualism as a diagnosis within the manual. In 1994, the DSM-4 changed that diagnosis to gender identity disorder, but not much of the content really changed. However, in 2013, with the release of the DSM-5, there was a significant amount of content that was changed. The name was changed to gender dysphoria. the DSM-5 specifically states that gender nonconformity in itself is not a mental disorder. The goal of keeping it within the DSM was for the diagnosis to focus on gender identity related stress and not gender identity itself. The goal was also to aid in support of psychiatric, medical, and surgical treatment. This was also the first time there was separate diagnostic criteria for adults and children. There's also a post-transition specifier added. And this was still having it within the DSM. There was still a little bit of controversy with this because regardless, having a diagnosis is still stigmatizing within our society. So, they are looking at that. They are working with medical professionals and people within the field. And hopefully we can see some additional revisions in the DSM-6 whenever that makes its appearance. In 2019, the World Health Organization declared that transgender identity is no longer a mental illness. Science supports this. It really supports that it is not a choice. It is not a mental illness. It is biological. There are twin studies of trans folks that show both twins are more likely to be transgender if they're identical twins rather than fraternal twins. There's additional studies that show exposure to varying levels of sex hormones in utero may have an impact on gender identity in development. And touching on conversion therapy, unfortunately, conversion therapy is still a thing. Conversion therapy aims to change the sexual orientation or gender identity of LGBTQ plus identifying individuals. Both licensed mental health professionals and various spiritual advisors may perform conversion therapy. Roughly 700,000 LGBTQ plus adults have received conversion therapy at some point in their life. It often results in increased guilt, further mental health issues, and increased suicidality for the person. Professional organizations including APA, NASW, and AMA have made statements indicating that variations of sexual orientation and gender identity are not indicative of a mental illness, and conversion therapy is not effective and can lead to further severe emotional distress. So as we look at conversion therapy laws today, there is a full ban of conversion therapy in 20 states. There is a partial ban in only one state, which is North Carolina. The governor of North Carolina banned the use of taxpayer dollars for conversion therapy practices, but does not fully prohibit the practice by state licensed professionals, as other states have done. There are 3 states, Alabama, Florida, and Georgia, in which the 11th Circuit Court of Appeals issued a ruling preventing the enforcement of conversion therapy bans within that circuit. So those 3 states are affected within that. And there are actually no laws or policies mentioning conversion therapy in 26 states, and I believe 4 territories as well. So looking at trans persons today, as we are speaking right now, the basic human rights of a trans person are being debated. It really has become a quote unquote political issue. Just different things we're looking at: bathroom bans, sports bans, medical care, military bans, change of name and gender legally, things along those lines. As I was discussing all of the breakdown of the laws in the different states regarding conversion therapy, that came from a website, www.lgbtmap.org. It's a really, really cool website, and I really encourage you guys to go take a look. You can break it down by issue, you can break it down by state to see how your state is lining up with other states. If you are passionate about a certain issue, you can check to see how the whole United States and all territories break down for laws regarding those issues. It really is a cool website, and you can spend a lot of time on there just really educating yourself and seeing where we're at in this country in regards to giving trans persons the rights that they deserve. Within the United States, we know that approximately 1.4 million adults identify as transgender. That's less than 1% of the population. A high number of people self-identified as transgender in younger populations, which I think is pretty expected. We are seeing a lot more comfortability in the younger populations than we may with folks who are older. Approximately 7.37 million people have an intellectual or developmental disability. That's less than 3% of the population. So as we're looking at the intersectionality of both these populations, we are looking at a very small number of people, but it's just as important because you know, these folks are individuals, and it's really important that we are treating each person as an individual and giving them the services that they deserve as we work with them. Different considerations to look at. Overall, there's just a lack of research, specifically with these two populations. In regards to the IDD population, there's just generally a greater focus of research on mental illnesses as opposed to intellectual and developmental disabilities. There's also a greater focus on sexual identity within the LGBTQ plus community when we're looking at research from that community. Research largely relies on self-report to collect data within the LGBTQ plus population, and people may not feel safe disclosing that they identify within that group of people, or may not feel safe disclosing specific information if they are participating in any form of surveys. Also, intersectionality is super tricky. Despite us talking about these two populations together, it's also important to consider the hardships that people may have experienced because of other identities that they have, including race, religion, things along those lines. As we look more specifically for considerations for the IDD population, a lot of people will say, do they even have the mental capacity to understand gender? Again, there's not a lot of research on this. However, studies show that a newborn is treated differently immediately after birth, just based on their sex assigned at birth. So gender is really coming at us from the second we are born. And gender roles are so deeply rooted within our society. It really is, in my opinion, hard to believe that, you know, someone may have absolutely no clue of what gender and gender roles are around them. A developmental delay may impact the development of a person's personal gender or sexual identities. A lack of declarations or self-identification does not necessarily mean a person's gender identity aligns with the societal norm within the binary. Behavior is communication. So even if a person does not have that language to express how they're feeling, maybe their behavior might be as well. And education is always really important as well. Unfortunately, sex and gender education is something that a lot of folks within the IDD population don't have the privilege of receiving. I know things are changing on that end, which is great. But for many of those folks, as that curriculum starts to get implemented, it is starting from scratch. There's an overall lack of independence, unfortunately, within the IDD population. just things to consider. Who is picking out their clothes, their room decor, the activities that they're doing both inside and outside of the house, the TV shows they're watching, things like that. Are we naturally gearing it towards their sex assigned at birth, or are we genuinely giving them the choices and the options to pick those things because they truly enjoy them? And folks within the IDD population also want to please their caregivers so incredibly much. They care about their caregivers so much, and they want to please them and make them happy. And they will do things that may not be true for them in order to do so. So it is really important to take that step back, not get caught up in the moment when we are working with the folks that we work with, and make sure that it's genuinely something that they want to do and not pleasing the people around them. Looking at cultural disparities, this is going to be both for the LGBTQ plus population and the IDD population, because there's a lot of overlap there. Individuals identifying within the LGBTQ plus and or the IDD population can carry additional stress and risk factors as members of stigmatized minorities. They are a vulnerable population as well, and people often experience violence and trauma at the hands of their loved ones, caregivers, peers, or community members. And these individuals also experience systemic oppression. So these are all things to consider as we are working with these populations. Just various risk factors. This by no means is an exhaustive list, but we are looking at possibilities of minority stress, lack of family acceptance, bullying, abuse, and trauma, tobacco, alcohol, and drug use to maybe cope with some of these things, low self-esteem, lack of appropriate health education and health care, and intersecting risk factors with other minority identities. All right, so I'm going to give the stage back to Leah as she goes through some literature.
Thank you, Emily. Okay, so in general, the ABA community has not done much research specifically on trans people within this specific population. That being said, there's a lot that can be done, and there is some that touches on these topics, but not in the best ways. The only article that I was able to locate that directly discusses the use of ABA with a supposed gender nonconforming person is Rakers and Lovas, 1974. The behavioral treatment of deviant sex roles in a male child. This article states that there was success in treating a child for deviating from expected gender behaviors, and that this is the first of many children treated in this way. The subject was a 5-year-old who was assigned male at birth. The target behaviors were non-conforming behaviors with the goal of reinforcing masculine behaviors and punishing feminine behaviors. The behaviors were chosen based on the toys that the child chose, the imaginary play he was engaging in, and other things that typically children kind of engage in pretty fluidly. The methods used included a token system, reinforcement, and punishment in the home and clinic setting. And the child's behaviors were assigned a colored token for feminine or masculine behaviors, and this was used as the data on the target behavior and as a visual for the token system. The mother was taught to provide praise and provide reinforcers such as preferred candies for behaviors leading to blue tokens on the token board. To extinguish feminine behaviors when he would engage in them, a red token was added to the token system and no social or tangible reinforcement was provided. The mother was also coached to ignore feminine behaviors or disengage with him if interacting when he begins to display feminine behaviors. Specifically to target reduction of feminine behaviors, the child's father punished receiving red tokens with timeout procedures, removing preferred activities, response cost of removing blue tokens from his token board, and spanking him based on results of the token system. The article specifies that the mother acted as the therapist in the clinic setting to differentially reinforce masculine and feminine behaviors, but the token system needed to be implemented in the home to help generalize. We will discuss the long-term effects for this specific child shortly. And I think it goes without saying that this is problematic for many reasons. If you agree, you're not alone in that. Several others in the field at the time responded to Rakers and Lovas. We'll go over two examples that most directly address the original article and identify problems regarding ethics and overall inappropriate use of ABA methods. Winkler in 1977 challenged using sex roles as a target behavior since this is subjective. Winkler also expressed concern that Rakers and Lovas were poorly representing the field of ABA by implying that empirical evidence supports the behavioral treatment of this child. Although research was used to support the effectiveness of various methods used, such as token economies and differential reinforcement, it was misdirected at best. Winkler acknowledges that the potential detriment of the experiment is greater than the child's personal concerns about their own behaviors, implying that this was not socially significant for that child. This raises the question we often encounter: who are we treating? Nordyke, Baer, Metzel, and LeBlanc, 1977, address many of the same concerns as Winkler, including the target behavior definitions and who the behavior change goal would benefit. Nordyke et al. Criticizes the use of punishment for feminine behaviors rather than strictly focusing on skill building what the target goal was, increasing masculine behaviors, although also acknowledges that this is ethically problematic as well. The article questions the behaviors modified and whether or not those truly relate to or can affect gender identity. The specific measurements were taken based on toy choices, friend choices, gestures, and play behaviors. As a 5-year-old who is exploring their world and using their imagination to learn and grow, it is a bit of a stretch to think that their toy, friend, gesture, and play choices will cause them to become transgender, which at the time was considered to be deviant. Nordyke et al. Also suggests goals and final outcomes for this study be determined and monitored more objectively. Rakers, without Lovas, defended the social significance and ethicality of this study in response to the criticism received. In the follow-up article, Rakers classifies the intervention as necessary to treat current psychosocial maladjustment and to prevent even more serious maladjustment in the future. At the time, homosexuality was considered to be criminal and transgender people were diagnosed with transsexualism, an official mental disorder, as Emily stated. As previously stated, it is difficult to objectively define a child's behaviors as masculine or feminine, or even more difficult to identify how modifying them will benefit or affect his future. However, Rakers felt the treatment was intended to prevent sexual deviancy and claims the child would have endured punishment from peers, thus the treatment was socially significant. He also stated that the parents requested the treatment, so it was significant to the family, especially to uphold their Christian values. I have mentioned this earlier and I'll mention again, treatment goals should be intended to benefit the person's own life rather than designed to improve or remove perceived inconveniences and challenges to the caregivers' lives. The final statement in Rakers' response is, "We did not advocate this treatment for a normal child rearing. We only reported on a success for changing the sex role behavior adjustment and gender identity of a single gender disturbed boy, an intervention that was ethically and psychologically appropriate. Thankfully, Jabba and others in the field have determined that this study does not appropriately disseminate the benefits of ABA for making socially significant changes, and that the article has been harmful and has the potential to cause more harm." In addition to Winkler 1977, Nordyke et al. 1977, as well as other direct responses to Rakers and Lovas 1974, many people contacted Jabba regarding this article with the goal of alerting the Society for the Experimental Analysis of Behavior Board of the harm that has been caused in the past and expressing concerns about how this type of information could be misused to cause more harm in the future. The Committee on Publication Ethics reviewed the paper and available associated information. Criteria for retraction include 1, a clear and defensible evidence of scientific misconduct, 2, falsification or fabrication of data, and 3, clear ethics violation. Based on the ethical standards in 1974, no ethical violation was detected. However, Jabba issued an expression of concern to outline various harms that could have or could in the future be caused, so that anyone looking up the article now will be directed to the responses to it. I feel this was an important step as it shows growth in the field and efforts to practice ethically and to hold ABA practitioners accountable for potentially harmful uses of ABA and misrepresenting the field as a whole. Anderson Cooper discussed this study in a 2012 three-part video series titled The Sissy Boy Experiment. During a follow-up in 1987, when the child from the experiment was 18 years old, he identified as a male who was happy with his gender. Whether or not this study impacted his gender identity cannot be determined, as there were so many other variables that could not be controlled or accounted for between the ages of 5 and 18. His parents reported in the video series that they feel participating in this study very negatively impacted their family in many ways. The largest impact, tragically, was that the study of the subject died by suicide at age 38. We know that correlation is not causation, so the suicide or any contributing factors to that suicide cannot be directly linked to the study that he unwillingly participated in at the age of 5. However, I feel it's fair to say that accessing reinforcement and punishment based on the gender assigned to your play behaviors as a child is very likely damaging in many ways. As Emily mentioned, members of the LGBTQ+ population are at a higher risk for several things, including suicide. Efforts to alter or correct someone's sexual and/or gender identity can have long-term harmful effects. We'll discuss the effect of reinforcement and punishment of gender identity and expression later. Barlow and Agras, 1973, Fading to Increase Heterosexual Responses in Homosexuals, is another problematic use of ABA. This study addresses the use of ABA procedures to alter sexual orientation. Although this is not focusing on gender identity, it shows that ABA practices have the potential to be used to alter sexual identity under specific stimulus control, which could have harmful connotations. The subjects of this study were 3 cisgender males, ages 21, 29, and 30. They identified as homosexual and wanted to become heterosexual, so volunteered for this study about fading in attempts to change the sexual orientation they most identified with, despite efforts not to. The targeted behavior was homosexual desires, which was measured both objectively by the response of penile circumference when shown various images, and measured subjectively based on reports of heterosexual interest when images were shown of a nude man and woman. During the study, subjects were shown a photo of a nude male on a projector, which, over 5 photos, faded into a nude female by slowly altering the body type and features to become more feminine. The goal was to arouse the participants with a photo of a nude male to pair physical arousal with an image of a nude female. The results of this study showed that stimulus control can be altered to train heterosexual responses. However, those responses can be affected by environmental contingencies as well. If heterosexual thoughts and behaviors are not reinforced in the natural setting, automatically or socially, those trained behaviors and heterosexual responses may be weakened or extinguished over time. Long-term, some of the participants still experience discomfort and fear when attempting to interact romantically with females. Although the participants in this study were volunteers and their long-term goal was to engage in and enjoy heterosexual behaviors, the implications of this study are that sexual orientation can be changed with stimulus control. This occurs by introducing an unconditioned stimulus, the photo of a nude male, to create an unconditioned response, the penile circumference increase, and then fading the conditioned stimulus into a unconditioned stimulus into a conditioned stimulus of the photo of the nude female to elicit conditioned responses, which would be the feelings of arousal. The results also support the role of following up on classical conditioning using operant conditioning for efficacy, as the immediate responses were to be altered, but long-term behavior change was not accomplished, most likely due to environmental contingencies not continuing to shape these covert behaviors. Articles like this can be harmful to the LGBTQ+ community, as they imply that conversion therapy is acceptable and, at least temporarily, has the ability to be effective. Alrighty, sorry. The results of this study showed that stimulus control can be altered. So we want to make sure that we are being very careful when interacting with our clients, that we aren't consciously or subconsciously kind of putting those tidbits into our time with them. Additional research is required. Journals such as the Journal of Applied Behavior Analysis, Behavioral Interventions, Journal of Experimental Analysis of Behavior, etc., have not published any research regarding the efficacy, potential benefits, or most effective uses of ABA for transgender clients with or without IDD. It can be implied that there is a lack of research being completed about this for special populations, but as stated before, unique populations will benefit most from individualized therapies. For ABA, each individual's treatment plan should be tailored to their specific demographics, identities, support needs, and behavioral concerns. We were unable to locate any research, behavioral or otherwise, specifically discussing transgender folks with IDD. One study by Busa et al. 2018 discussed anxiety with transgender youth. It noted that cognitive behavior therapy should be an effective method of therapy for transgender youth when paired with gender-affirming therapy, but that it has not been empirically proven. The article does not mention the intersectionality of IDD, but it does emphasize the need for more research to appropriately support the transgender population. All right. And we're going to take a break now. Anna, did you have anything to say before the break? Anna? All right, well, let's do a 10-minute break. So come back around 1:57 and we'll get started again. Thank you. Okay, welcome back from break, everyone. We're gonna get going again. There weren't any questions in the chat box thus far. If you do have any, though, go ahead and put them there, and at the end we can go over them. Okay. So some of the main focuses of ABA include complete and thorough assessments, socially significant goals, the effects of reinforcement and punishment on future behavior, and for most current practitioners in the field, radical behaviorism. We will explore how these individually can be important to consider while working with the trans person with IDD. Just as we use assessments to identify skills to target, we can and should also use assessments to individualize behavior supports, since behavior analysts already go through this assessment process. There are some things that can be added to your current assessments to be more inclusive. Individuals with IDD often lack the freedom to make choices in their lives. Regardless of perceived importance of those decisions, this impacts overall sense of control. Especially if someone has varied or inconsistent preferences, this is important to assess. People with IDD often have less ability to make choices in their lives, and therapeutic efforts can be allowed by giving that person control of their time in therapy. Stronger reinforcers can be identified if the person indicates that they are preferred rather than if this is assumed. A trans person with IDD may need to be encouraged to make choices for themselves due to potential past denial of the ability to or comfortably make meaningful decisions for themselves. It is your role as a supportive ABA provider to reinforce choice making and self-expression. This can also assist with pairing and individualizing supports. As Emily explained earlier, terminology can be fluid, and it is important to determine how the person themselves prefers to be identified. Someone with IDD may have varying ability to self-identify or express themselves clearly and may require prompting. It should never be assumed that a client is any specific gender or sexual orientation, and it is much better to ask and show that you're dedicated to respecting that person than guessing very personal things about them. Interview questions for the person themselves can include: do they have supportive loved ones? What was or is school like for them? When do they feel the most comfortable? When do they feel the most loved? And this initial interview can also provide opportunity to welcome the person to give feedback while working with you if anything is making them uncomfortable. It is common for both transgender people and people with IDD to have experienced trauma in some form throughout their life, so the person can be offered the opportunity but not forced to share anything that may be valuable to know. If someone is expressing feeling misunderstood or indicates that they have accessed social punishment, this may affect their overall concept of expression of self. When we openly cannot observe private events, they are still valuable to explore, as they can relate to overt behaviors and alter the appropriate course of treatment. It may be difficult for the person to be comfortable sharing some experiences, in which case they should be validated and informed that their behavior analyst will always listen if they would like to share anything in the future. While conducting interviews with families, friends, and other caregivers, it is not uncommon to experience biased opinions about the person and information that may not be fully truthful. Be mindful of the comfort level of caregivers and how this may be affecting the person's ability to accept and express their true selves. If this is indicated, it can be reasonably expected that the person may have experienced some rejection and trauma in their life from those who care for them most. Do the caregivers respect the person's gender, self-expression, and identity? Do they feel the person may not fully understand gender and sexuality due to their cognitive ability, as Emily said may be the case earlier? Have they encouraged this person to be comfortable with who they are and welcome them warmly? All of these factors can inform both potential contributions to influencing target behaviors and personalizing the treatment plans. If previous behavior data is available, this can be considered as usual, but take into account the date of the data and any recorded or shared traumas or social stressors at that time. For instance, if someone was moving from home to Asila, they may have shown different and challenging behaviors. For a trans person with IDD, if there was a specific moment when they began to express or identify differently, this could have a large impact on behaviors. If there is documented social history, consider the effects of this in relation to the data and previous behaviors reported. Identifying and acknowledging every social influence would be impossible for anyone, but someone who is more likely to have experienced adversity for simply being themselves most likely has accessed various forms of social reinforcement and punishment regarding their identity. Has this person received any type of therapy in the past? If so, what were their reactions to it? Have they participated in sexual or gender-specific therapy? If so, was this punishing or beneficial? Have they received ABA services in the past? And if so, what were the target behaviors and the functions of those behaviors? Could they have been related to social stressors? Was there anything particularly triggering about that during past services? There's an endless list of considerations that should be taken while working with any client. However, it's important to identify and be open to adjusting services based on past experiences. As always, skill acquisition goals and target behaviors should be determined based on the assessment of the individual, which requires understanding potential challenges they've experienced in the past and or are still experiencing while you're working with them. It is very important to note any reactivity that the person may be showing to your presence or specific behaviors. This can inform how to best interact with the person going forward. Make note of whether various common interventions may be more traumatizing than beneficial. For instance, attention extinction or differential reinforcement with extinction may be upsetting if the person has experienced a lack of social support. Could physical prompting, close proximity, or certain body languages be interpreted as intimidating or triggering? You can get a general idea of some of these things by simply remaining aware of your own and the person's behaviors during assessments. During the social assessment process, if the behavior analyst feels that a person will be unsuccessful with behavior supports due to social factors or past traumas, it may be appropriate to refer the person to receive additional supports as well. In behavior analysis, all goals and practices should be socially significant, therefore have social validity. Cooper, Harrod, and Heward, 2019, defines social validity as the extent to which target behaviors are appropriate, intervention procedures are acceptable, and important and significant changes in the target and collateral behaviors are produced. As discussed, Rakers and Lovas, 1974, lacked social validity, which was made clear by the responses of some critics in the field. Above all, the behavior targeted for change must benefit the person in a way that is important and valuable to that person. The opinions and benefits of others, such as family members and caregivers, should not be prioritized above the individual themselves. To ensure social validity, it is important to consider any potential variables that may influence the treatment and effectiveness and outcomes. What is socially valid for one person may not be for another, and what is socially valid for one person right now may not be socially valid in the future under different circumstances. Each client, regardless of diagnosis, sexual orientation, gender identity, or any other demographic factors, deserves individualized treatment plans that takes into consideration past history and potential trauma. It is my belief that without these considerations, treatment is risking not having social validity as we are not taking into account all of the potential components. This could include and influence outcomes. Intentional efforts should be made to acknowledge individual experiences and therapeutic behaviors or barriers. Any person who is part of a vulnerable population has likely experienced being misunderstood or or undertreated. When discussing transgender people who have IDD, they are part of a very specialized population, and this is not commonly discussed during ABA graduate programs. This means when a practitioner encounters a client of this population, they must choose between providing more generalized support, which may be harmful for various reasons, or choose to educate themselves to become an advocate and inclusively support this person. Especially if working on social behaviors, the values of the client must be considered when creating goals. If ASILA would like the client to interact more with peers, but that person values alone time and space and perhaps is uncomfortable around others due to fear of judgment or rejection, it is not appropriate to target increased interactions with peers without building tolerance for this first. A future goal could be beginning to build tolerance in social settings to help them through this. All people have a history of reinforcement that has been building for their whole life. For clients, this begins long before we meet them, and as discussed with assessments, past experiences can enlighten current services. We may not be fully aware of what is involved in that history, how they've accessed reinforcement, and how past behaviors have been punished. In the assessment process, it's important to attempt to gather as much information as possible to be aware of how these experiences may have shaped the person's perceptions of themselves and receiving behavior supports. If someone historically has accessed more reinforcement for expressing themselves as they identify, they are more likely to have higher self-esteem. To break that down, we're going to talk about how people can access reinforcement in different ways. Reinforcement, as we know, strengthens the behavior it follows, making it more likely to occur in the future. And with this in mind, we can examine how various expressions and identities for transgender people can access both positive and negative reinforcement. It's also important to note here that we do not have the ability to identify someone's gender identity based on appearance and behaviors alone, and expression of gender can be fluid. So a male may want to wear clothing deemed masculine and present themselves with the appearance of society's expectations of a male one day, but wear a dress the following day. This is fine and should be accepted. These examples are to discuss the effects of receiving reinforcement and punishment for behaviors that either express or disguise someone's gender identity. Ultimately, this comes down to whether or not someone feels safe or comfortable enough to express oneself openly. If someone accesses reinforcement for behaviors that align with their gender identity, aka being their true self, they can access positive reinforcement in the form of validation and social acceptance, positive reinforcement by being encouraged to be open and self-express without altering themselves, and negative reinforcement by avoiding uncomfortable feelings such as being ingenuine in self-expression, being stuck in the wrong body, and having suppressions of self. The person who accesses reinforcement for being their true self is less likely to have low self-esteem and more likely to be comfortable expressing their gender identity, thus increasing self-acceptance. On the flip side, if someone accesses reinforcement for altering their gender expression to something other than their identity, aka masking their true self, they can also access various types of reinforcement. Hiding one's true self can access positive reinforcement by gaining social acceptance, access positive reinforcement in the form of maintaining social and familial relationships, and negative reinforcement by avoiding stares, judgment, criticisms, questions, etc. Overall, when someone is accessing more reinforcement or more desirable reinforcement for disguising their true gender identity, it is more likely to continue, and this person is more likely to experience low self-esteem. Emily has already explained some of the increased risk factors for people who are transgender and how those can increase when someone also has an intellectual or developmental disability. It is important to identify ways in which someone can access positive reinforcement through what is most natural and comfortable for that person. When someone with IDD has a specific person that they look to for guidance and support, similar to what Emily was saying, those individuals have a large responsibility to provide the appropriate type of care and guidance. If these key people in someone's life respond more favorably when the person is disguising their true self, however, the loyalty the person shows to caregivers may take over and create the desire to suppress their expression of gender. And we can't talk about reinforcement and leave out the effects of punishment. So again, as you know, punishment weakens the behavior it follows, making it less likely to occur in the future. Just as with reinforcement, we can examine how positive and negative punishment can affect a person and their behaviors. If someone accesses punishment for behaviors that align with their gender identity, aka being their true self, they can access positive punishment various ways. Being told that they are not the gender they identify as, being told they are dressing, speaking, or otherwise behaving incorrectly in accordance with their sex assigned at birth, potentially reprimands from loved ones, teachers, staff, and strangers, which in some cases has the potential to escalate into physical violence, being subjected to forms of conversion therapy, and being told that they do not understand their own identity. Negative punishment can be accessed for expressing one's true self also by losing the important relationships due to disapproval of others. The person who accesses more punishment for being their true self than for disguising their true self is less likely to be comfortable expressing their gender identity, thus decreasing self-acceptance and increasing risk factors for maladaptive behaviors and some of the factors that Emily mentioned. While considering transgender people with IDD, these forms of reinforcement and punishment may be perceived differently. In general, someone with IDD is more likely to need support from loved ones and caregivers for many things in their life, and they're less likely to have total independence of their choices, whether it be their name, clothing, personal pronouns, and so many other things. Unfortunately, it is also more likely for someone with IDD to be challenged as not understanding gender and instead being told you are male or female accordingly, which at that time could be untrue. Without strong self-advocacy skills, It can be difficult for someone with IDD to have discussions to explain that they are transgender, how this is their identity, and why they have the preferences they do. The punishing effects of having IDD and being transgender can be severe, and without a strong advocate, the person may never gain the ability to express themselves fully. This can lead to an increase in challenging behaviors due to loss of sense of control over oneself, as well as increased difficulty in finding adequate support, as this is not a large population that is specifically supported by many. We'll discuss further in detail later on how you as a clinician can make intentional efforts to support your clients who are transgender and also have IDD. While practicing radical behaviorism, we acknowledge to seek and understand the ways that external environments influence private events and how those separate behaviors that are these thoughts and feelings influence our overt behaviors. While working with any client, it's important to rely on the person's report of their experiences, thoughts, and feelings. If the person is unable to vocalize or otherwise communicate their experiences or covert behaviors, it is important to consider possible influences without assuming what the person has experienced or dismissing private events entirely. As behavior analysts, we acknowledge and practice under the scientifically proven fact that operant conditioning has a large effect on human behavior. It would be irresponsible to assign blame for the client for their particular maladaptive behavior instead of doing the work needed to identify the function and most effective function-based interventions. We should aim to understand that whether or not someone's gender identity aligns with their sex at birth, they have experienced feedback from their verbal community that has contributed to shaping how they express their gender. However, as we discussed with accessing reinforcement and punishment for either acting or disguising one's true self, gender nonconforming behaviors may be subjected to ridicule and rejection. These external events can lead to internal events such as having low self-esteem, discomfort or dislike of oneself, the desire to be more guarded, and feeling unsupported by one's verbal community. It would not be surprising if someone whose gender identity has been challenged displays more guarded behaviors for this reason. For a transgender person, this could include, as discussed, choosing to express themselves as their sex assigned at birth instead of their true identity to avoid conflict and rejection. This could also include distrust of others and potential disinterest in therapeutic support due to the vulnerability it requires and overall need to adapt to various environments. For a trans person with IDD who requires support from caregivers, overt behaviors may reflect internal events that are difficult to process, request support for, and/or express clearly. If the person who helps you make decisions and navigate your daily life does not accept your identity, this recurring rejection can be damaging and cause unpleasant internal events. We cannot remove their person from their history of reinforcement, just as we cannot remove the experiences someone has from the influences that those experiences have on their behaviors. As Emily mentioned earlier, gender and sexuality are not a choice. This was also demonstrated in the Barlow and Agras 1973 study, in which 3 males identified homosexual desires, although they so badly wanted to change this that they volunteered for a form of conversion therapy in attempts to retrain their brain. Ultimately, this did not have long-term effects of being successful. The newly shaped arousal for heterosexual thoughts was not maintained by experiences outside the study. The subject's internal events and overall environmental stimulus control outside of the study was stronger than the temporarily trained response to contrived stimuli within it. A key point of radical behaviorism is that the world is an orderly place in which consequences determine future behaviors. Determinism gives us reason to do assessments and to identify functions of behaviors. If behaviors were random and chosen by free will, we would not need to or be able to identify a function or contributing variables for specific observable behaviors. If a client is transgender and has IDD, their behaviors may have been subjected to consequences specific to their gender identity, which is unable to be separated from the person themselves. In this situation, the person's identity is being dismissed, challenged, or otherwise not accepted. They may have specifically experienced attempts to change their behavior similar to, but not likely as thorough as the 5-year-old subject of the Rakers and Lovaas 1974 study. This should be taken into consideration when analyzing behaviors. Past and recent interactions with others may have been punishing, leading to discomfort with accepting support for behaviors. This may create a therapeutic barrier if the client feels the need to guard themselves to feel safe and accepted. A lot of information has been presented, and I hope that much of it was met with an urge to better the field and model how ABA providers can support trans clients with IDD. While we do not have specific research telling us exactly how to best support this population, there are intentional efforts we can make to individualize support plans with necessary considerations in mind. The field of ABA has received criticism for not acknowledging the effects of thoughts and feelings on a person and focusing too largely on observable behaviors. As discussed, radical behaviorism encourages us to identify these internal events as specific behaviors that influence overt behaviors. We should avoid simplifying observable behaviors as we see them in the moment without considering the shaping that has occurred. Present data can only show us the current presentation of that behavior, not progression of the behavior over time, unless you were able to gather that and link it with social stressors. We have previously discussed the need for thorough assessments. In addition to frequent and wide-ranged preference assessments, it may be beneficial to focus on historical behaviors and social histories, as well as the attitude of caregivers towards this person and their behaviors. While identifying and defining target behaviors, ensure that they are valuable to the person being served and that they acknowledge them as an individual. They should not be solely focused on the views of others. Replacement behaviors are meant to be alternatives to the maladaptive target behavior, and since being transgender is not maladaptive, a target behavior should not involve modifying anything having to do with gender. You cannot and should not aim to replace how someone feels, identifies, or perceives themselves in any way. Remember also that trauma histories can strongly influence private events and observable behaviors. If covert behaviors are not supported, overt behaviors may be more difficult to target. Without supporting recent or past trauma, long-term behavior change will be more difficult to achieve while focusing on current presentation of behaviors. As previously discussed, trans folks with IDD may have a difficult history when it comes to reinforcement and punishment for social behaviors. The person may have been denied social reinforcement or have experienced more aversive interactions than reinforcing. This can impact the person's motivation to work towards behavior goals and can impact the effectiveness of social reinforcement. They may, in fact, have become more comfortable with inappropriate social behaviors over time if these have accessed certain types of consequences more predictably. You can help your client feel safe with you and more comfortable with your services by reinforcing expression of self. Ideally, this reinforcement could be generalized to the outside and remain outside of the clinical setting long term. Functional communication training is implemented in most behavior support plans as the benefits are extremely universal. For someone to be comfortable expressing their wants, needs, feelings, thoughts, they must be comfortable doing so and believe that they will access reinforcement for self-expression. Someone who has accessed social punishment in the past may also struggle to tact feelings and express themselves completely. For transgender people with IDD, the challenges of intersectionality of these identities can increase difficulty with explaining internal events. Self-expression for someone in this population, as discussed, has likely been punished at some point in the person's life, so there may also be confusion regarding feedback from their verbal community, making it difficult to navigate communication. Another frequent focus of behavior therapy is stimulus equivalence and generalization. For someone who has likely been misassociated with various features or populations, this can present a challenge. There are few, if any, social models of trans folks with IDD for someone to identify with. While training discrimination, it should be acknowledged that people cannot easily be categorized in standard ways as animals or items can. Be mindful of materials used while working on equivalence training. I have personally come across many materials prepared with direct and indirect gender connotations. So if asked to discriminate between certain characteristics of each gender based on cis-normative standards, this could be discouraging at best and damaging at worst. The person may also be experiencing uncertainty of how to equate their own identity, which can be confused if therapeutically trained that everything falls into a definite category. Flexibility can allow for generalization more often, and this is not to say that stimulus equivalence or discrimination should not be used. Rather, they should be approached with caution and intentional consideration. For the most thorough and experienced, even though the most thorough and experienced ABA provider cannot be effective without generalization of supports outside of the therapeutic setting, it's important that we acknowledge the family's role in that. So if family or caregivers do not support someone's identity or self-expression, they're less likely to participate in the person's therapy in a meaningful way. Make time to work with primary caregivers to express the progress that the person is making and ways they can provide reinforcement for specific target behaviors not relating to gender. It should be explained how accessing reinforcement across settings and people can increase effectiveness of treatment to provide additional motivation to participate. If successful, the person may receive more reinforcement for appropriate behaviors in the home setting, which is more likely to make long-term behavior change and can help build a more trusting relationship with caregivers. Be mindful while working with caregivers that it is not the place of a clinician to out someone by sharing any personal details that have not been shared already. As you all know, the BACB has outlined very strict and well-defined code of ethics. Supporting transgender clients in the IDD population may require some additional attention to ethical codes. We will now briefly discuss some ethical codes that should be specifically considered while working with a specialized population, although all codes should be followed at all times to apply in some way. Code 102 states that practitioners must practice within their boundaries of competence. 103 requires maintaining competence through professional development. As previously stated, the literature we so heavily rely on while creating support plans does not identify specific practices for this population. You can remain ethical by making efforts to educate yourself on the intersectionality of various identities and using these to inform your clinical decisions. Potentially the most relevant code to this presentation is Code 105, Professional and Scientific Relationships. Specifically, Code 105C states where differences of age, gender, race, culture, ethnicity, national origin, religion, sexual orientation, disability, language, or socioeconomic status significantly affect behavior analysts' work concerning particular individuals or groups, behavior analysts obtain the training, experience, consultation, and/or supervision necessary to ensure the competence of their services, or they make appropriate referrals. Code 105C, Code 105C states that behavior analysts do not discriminate based on the aforementioned demographics, and 105D specifies that behavior analysts do not engage in harassing or demeaning behaviors. In line with practicing within boundaries of competence, Code 201 states that a practitioner should accept clients whose required services are aligned with the behavior analyst's education and experience. Expanding research and ongoing educational efforts will increase your ability to work with a variety of clients. If possible, a behavior analyst can request supervision from a BCBA whose experiences do align with that specific client's needs. Code 205 states that a client must be notified of their rights. We can go beyond acknowledging and upholding basic rights by treating the whole person while considering the factors of intersectionality in their individual identities. We have thoroughly discussed Code 209 throughout this presentation, which states that clients have the right to receive effective and efficacious treatment. Specific to this population is Code 209D, which states behavior analysts review and appraise the effects of any treatment about which they are aware that might impact the goals of the behavior change program and their possible impact on the behavior change program to the extent possible. Behavior support is much more likely to be effective if the person feels valued, understood, and is advocated for by their ABA provider. We have discussed the following codes already in great detail. Code 402 notes that there are ethical requirements to involve clients in treatment planning and to obtain consent, just as giving choices will allow the client to feel more in control. Participating in their treatment plans can also help increase sense of control, as well as motivation to actively participate in treatment. Code 403 emphasizes the requirement to individualize treatment programs. Focusing on any and all personal identities will help achieve this. Attending to Code 408 and 410 involve assessing punishment and reinforcers and how these can affect a client. Predicting potential problematic punishment procedures and reinforcers can be supported with assessment, and all accommodations possible should be made to avoid anything that may be harmful and not beneficial to the client. Remember, forms of punishment and reinforcement are not universal for each person, so they should be carefully analyzed on an individual basis. Code 602 assigns behavior analysts the responsibility of disseminating behavior analysis. Since there is not current behavior analytic work focusing on supporting people who are transgender with or without IDD, any information obtained or discovered could benefit others in the field if disseminated appropriately. Code 701 simply states that a behavior analyst must promote an ethical culture in their workplace by upholding the code of ethics. Again, although I've pulled some specific codes that more directly relate to transgender people with IDD, the entire code must be followed and modeled for colleagues. Code 702 specifies that if there are legal or ethical violations, a behavior analyst must be able to assess the situation for potential harm and follow through with any necessary legal action, mandated reporting, or by following specified policies. All efforts must be made to protect the client in cases where they are at risk of harm due to these violations. Since both the transgender and IDD population are more vulnerable in many ways, this code must be thoroughly considered and upheld.
All right, so I'm going to be taking over for the remaining of the training. We had the opportunity to communicate with two women who both have intellectual disabilities and identify as transgender. Oh, I'm sorry. Sorry, I'm tucking away my video here so I can see. They both identify as transgender. They wanted to share their stories to help increase awareness and support other people like them. So we'll share a bit of each of their stories. Both were comfortable with their names and images being shared with everyone today. So we first have Mariah. Mariah is a trans woman who wrote an autobiography about her experience. The book has since been published and can be found on Amazon, Walmart, and other big retailers. Anna is posting the link to, I believe, Amazon for you in the chat, so you can go and check that out yourself. But Mariah would like others to know that her book is a story of faith, hope, and overcoming obstacles. She wants to use her story to give hope to others that no matter what they are going through, that they can get through it and that they should never be afraid or ashamed to reach out to others for help. We also had the opportunity to communicate with Michelle. Michelle is a trans woman who has experienced bullying and discrimination because of her gender identity. When asked what she would like people to know about her, she replied that I will always be a woman and I can't change myself. Michelle also shared that she will, quote, tone it down, end quote, for the people around her and, quote, try to make it easier for them. And she struggles with presenting as her authentic self because of that. So in the beginning, I discussed a little bit about how folks with IDD really want to please the caregivers and the folks around them. And this is just a prime example of that. So how can we help? How can we raise awareness and create a supportive environment for trans folks who have IDD? Validation is a big first step. Validation can be tricky sometimes. It's the recognition and acceptance of another person's internal experience as being valid. This does not mean you're agreeing with the thought or the action. It's just stating, I recognize you and that you're feeling that way. It's really important to note that you can always validate the person. Many folks that we serve, they don't receive validation in general. The validation can help normalize their thoughts and feelings that a person may question. And whether it's a gender identity, a really hard experience that they're going through, or a behavioral outburst that we're working with, validation is good in almost every scenario. Looking at language choices and standard categorizations, just some different options for you. Include expanded options for pronouns within your documentation. Consider open-ended questions rather than yes/no questions, male, female, other questions, or any exclusionary language. You really want to demonstrate acceptance and reinforce self-expression when you're doing this. Something to consider as people are filling out documentation. Who is filling out that documentation for the client? Is it a staff or family or guardian? You should double check pronouns with the person if they're not filling it out themselves, just to make sure that you are communicating with them as they identify, as opposed to how their family or their caregivers are identifying for them. Another note is something you commonly see as people are trying to do this a little bit more. You may see a section labeled preferred pronouns. In general, this isn't best practice because pronouns aren't preferred. The pronouns listed are the person's pronouns, period. And that should definitely be respected. So utilize those pronouns identified by the person themselves and utilize reflective language whenever possible. Continue your own self-development. Continue to research best practices when supporting different populations of people. Generate discussions amongst your colleagues, share new findings, provide respectful feedback as it's needed, and engage in healthy dialogue, challenging thoughts and beliefs of the people around you. Be a model for other people in your field and demonstrate an understanding of non-judgmental therapeutic approaches. Remain inclusive of all populations and experiences, and embrace new experiences. New experiences are uncomfortable. We get it, and it's okay to mess up. We're all human, but just acknowledge that you were wrong and that you made a mistake and move on from it. There's no need to dwell on it. The best way to move forward is just by showing change behavior. Advocate for your clients. Ask what their goals are and how you can help them achieve them. Don't make assumptions for their wants and needs. They may not be comfortable sharing different things with different people, so you always want to ask if they would like you to advocate on their behalf and how they would like to see that done. We really don't want to overstep any boundaries and end up outing someone who may not be comfortable sharing that information. Have conversations with your coworkers. Again, really challenge people's beliefs and help them be the best clinician that they can. Something to note that Leah touched on a little bit in regards to ethics, misgendering a person intentionally can be an OIG reportable offense because it can cause emotional harm to a person. Some additional considerations. Never assume what a person wants or needs. Choices should always be provided to them. And this includes choices regarding everything and anything possible, but just some examples that we have. Voices on communication devices. If they're using a communication device, are there gendered voices on there? Which one do they want to represent them in the communication that they share with the world? Clothing style and their personal presentation, makeup, hairstyles, products, jewelry, shoes, things along those lines. As we're looking at personal care products, even down to the scents of the soaps and lotions that they use, the shampoo type, perfume or cologne, deodorant, things like that. Really important to point out once again, this can vary across time. If a person is wanting to present more feminine on one day and an hour or even the next day later, they want to present more masculine, that is okay. And they should have the choice to be able to do that on their own. And it's important to remember that these things do not have to be consistent with their gender identity. Other things to consider, which bathroom are they comfortable using? What bathroom do they have available to them at workshop, at grocery stores you may be visiting out in the community? As things start opening up again, and you know, if folks you have are in Scylla homes or even with families, as they're going out in the community, once again, what do they have access to? Things to think about, you know, especially if we're seeing behaviors occurring in the store. You really want to look into those things depending on how they identify. The bedroom decorations that they have, and just the general gender makeup of the environments that they find themselves in. in regards to SILA placement, is it an all male home, an all female home, or a mixed home, as well as their community day service programs as well. All right, so if you have any questions, now is the time for that. Leah and I do have our emails up here as well if you would like to email us with any questions. But Anna, do we have anything? We can take a moment to check the chat for ourselves. All right. Looks like some stories that people have encountered. How can we help individuals that live in the home accept our transgender individual? That's a really great question. Education is going to be really important as we are seeing that sex education is required for individuals. Bring gender into that discussion. That can be really helpful as well. Leah, do you have any additional thoughts on that?
So besides education for the others in the home or people they may come in contact with, I think just doing education for everyone. And I know that DHS is now requiring sex education for people who live in SILAs, which I think is a great step forward because it really does open up these conversations and leave opportunity to explain some things that may seem odd if that's not what you're used to. And especially if you're living with someone and aren't quite sure why certain things are how they are. So I think just in general, having conversations with others that may encounter that person, as well as helping the person themselves express themselves comfortably, again, reinforcing any expression that they're comfortable with and helping them feel truly themselves while also explaining to others if they do need to, because questions may arise that could be very triggering for the person themselves. But I think that arming them with the education of how to respond to those things and helping them become more comfortable answering those questions can be helpful.
As you're working with those different people in the environment as well, you want to make sure that the person you're working with knows that you are a safe person to come to. So while there may be challenges around them, at least they have one safe person that they can express as you work to advocate for them and change the views of the environment that they're in. Some people, particularly family members, may want to see the science behind it. And so looking up some of that scientific studies and information on that may be helpful for people to have a better understanding that this is something that is serious and should be taken seriously. I'm gonna check the chat for any other questions.
Can you scroll up a little bit more?
Mm-hmm. All right, I think that is about it. I'm not seeing any more questions on our chat. So thank you everyone for your attendance. Hello, Anna.
Hi.
Final words.
Thank you guys so much. It's a new topic for a lot of us. So I think some of us are just being quiet just because it's a lot to take in and process and we're thinking about things. And so I really appreciate a new topic like this and you guys taking the time to do that. It's awesome. Thank you guys. Just a reminder to everyone else, you will receive an evaluation from Jenny Gra. Fill that out and then send it back to her. And then she will get your continuing education filled out and sent back to you. And if you don't hear from her within 10 to 14 days, go ahead and reach out to her. I did put her information in the chat box. And she will also send out the PowerPoint presentation as a PDF today, along with the CE, so you guys have that. And I think that might be it. So have a great weekend, everybody. Thanks for taking time on your Friday to spend it with us. And Emily and Leah, thank you guys so much.
Thank you, everyone.
Thanks,
Bye, guys.
everyone. Bye.
Can you guys see me? I think you have to end the meeting, Emily, since you're the host.